move on to the master video session, and I have very, very able and experienced chairpersons to do the job. Dr. Sardar Naeem from Bangladesh. I don't think he needs any introduction in this part of the world. Dr. Anil Sharma from Delhi. If you don't know him, probably you are in the wrong hall. And Dr. Samir Rege, my friend from Mumbai. Where are you, Samir? Why can't I see you? Samir?
I am very much there, sir.
Ah, there you are.
You call me and I have to be there. No question.
So I'm very happy to hand over the chair to you all for the next 40 minutes on the master videos. And I'm sure Shiva, Ashwin, Sumanto and Jignesh are going to enthrall us. So over to you, Chairperson, sir.
Okay, well, thank you, Sarfraz. Thank you for the kind words, man. And on behalf of the organizing committee, I would like to welcome our speakers. We have some very eminent names out here that, and these speakers will share their videos and their expertise with us for the next about 45 minutes. So my co-chairpersons, Dr. Sardar Naeem from Bangladesh, and Professor Samir Rege from KEM Hospital, Mumbai. Well, welcome you all. And without much further ado, I would like to invite our first speaker, and that is none other than Dr. Siva Kumar. Dr. Siva Kumar is the founder of Siva Hospital, which is a state-of-the-art hospital in the southern town of Kanyakumari. Siva has been extremely active, not only professionally, but academically as well. And that is on various academic fronts. So, well, Siva, please take over the floor and show us the way that you do Schola. Thank you, Shiva.
Thank you. Very good evening. First of all, it's a great show for the organizing team and as well as IAGES. Congrats. Respected chairperson, there is so many techniques for the hernias. We found out there are A to Z. We have so many techniques, but for the divergence of recti with umbilical hernia, we come across challenges sometimes. So the clinical examination is the patient with the divergence of recti with small umbilical hernia. So what we are going to do here, that's just called a subcutaneous only laparoscopic approach for the ventral hernia and rectus abdominis dystasis. So we come across now onlay mesh, uplay mesh, underlay mesh, and intraperitoneal mesh, and inlay meshes. Here, what we are going to do in Scholar steps, first the position of the surgeon in between the leg and camera person will be standing left to the surgeon and right to the surgeon is a scrub nurse. And the position of the this one, legs are low lithotomy or leg spread position will be very good. So this is the theta setup, and the port position, first port is there is a 10 mm port in supraumbilical region with only 10 millimeter for the 10 mm port, and 5 mm port on both right iliac fossa and left iliac fossa and the paramedian line. Working port. So straightly I'll just go to the case scenario. This is a 10 mm port which I made supraumbilicusly, the dissection which is carried out initially by 10 mm 0° scope in subcutaneous plane between the fascias. Now after that you can introduce both the side right iliac fossa and left iliac fossa. You can introduce 5 mm port with a harmonic scalpel or bipolar or even the monopolar. We can dissect in the between the fascia here, fascia scarpa. So that is the bloodless field. We can just go into the plane up to the cephalosternum in the midline. So in between there will be a like umbilical hernia which we will come across. So this is the small umbilical hernia here. The main problem for this patient is the dilatation of recti. So this umbilical canal tunnel just keeping your finger from up not to injure the skin. So this detaching the hernial sac from the umbilicus. Yeah. Like you can see where I am showing that's the syphilis sternum. Up to the syphilis sternum around 15 to 17 centimeter the dissection is carried out. Now with I'm just taken a 2 ethylon, there is a loop ethylon from outside and just starting suturing from up from the syphilis sternum. This here I'm using a single suture it's not I'm plicating the rectus muscle, rectus sheet to create the linea alba. It's an augmentation of the linea alba. So the suturing is it's a little bit hard because the needle is very big and you need a strong needle holder. So you can see now I'm just trying to tighten it a little bit. So whole you can see the lax diastasis of the rectus. So this can be carried out up to the pubic symphysis. If your camera person is very good, so you can carry up to the pubic symphysis. If at all, if you are getting a huddles when you are getting coming nearby pubic symphysis, you put a 5 mm scope on the left side and suture from the right working hand as well as the camera port. When only problem when we are taking the suture, so knotting in the end in the pubic symphysis. So when how the gynecologist do the looping knot the same way, make a loop, rotate the needle inside around 6 to 7 times. Then your suturing hurdles will be over, because otherwise you have to just open 2 to 3 centimeter. You have to do with the hand suturing in the last. So otherwise this, if you want to do completely with this one suturing, then this is best way. Then you have to complete the suturing in the cardiac from the syphilis near syphilis sternum. So in the take the additional that's the same suture without which is left over in last. Take a one suture there and put a knot in the nearby syphilis sternum. Now pull the outer part which is left over. Then complete the suturing. So the augmentation is over. Now the you can see the midline. There is the linea alpha. New linea alpha is made. So only thing is now augmentation with the mesh. You can take a 15 centimeter to 12 to 15 centimeter mesh with the length of around 30. Depending on the patient, 25 to 30 centimeter length mesh you can take. You can put into the tunnel and we have to on suturing. So this complete the augmentation. This is a long mesh which I am just spreading over the rectus muscle. Now the fixation of the suture, I use 20 proline. Take a continuous suture from the right upper end to the hand. That's the patient to the patient left hand. Start a suturing, continuous suture. Then whole left our left hand side come down. Sorry. When you complete the left side, the left hand, otherwise on your right hand also, start suturing on the right side, the continuous suture. It's a simple like only problem when you are coming nearby the pubic symphysis, because Western people they used to do like open like around 3 centimeter, 2 centimeter in the pubic symphysis. Like the last knotting and suturing will be done by hands on. But like here, like the whole suturing will be done by the laparoscopic itself, because I am changed the position of the camera, like right side, right here. So this is after completion of the mesh. I used to keep the train, like 2 train suction train inside, like, and complete the case. Shafras?
Yeah. So
Over.
yes, it's over. Thank you.
So the conclusion is like in such a cases like site identification of recti, like in the simple method of subcutaneous layer, we can dissect and do the augmentation of the linea alpha, and keep the mesh, and we can get the nice like result. Like only thing like post-operatively we have to give the nice compression bandage. Thank you very much.
Dr. Siva?
Yeah.
Somaria, excellent presentation. Can you let us know what are the contraindications when you would not suggest this procedure to be done in the umbilical limit diastasis?
Only thing
You will not recommend.
Only patient have the vertical incision like from the umbilicus to down, like before previous surgeries. Yeah, they have the patient have. Or like huge obesity, like patient have so much of obesity. There is it's hurdles to go in, and there is a chance of too much of seroma formation. And this is the other things like which the patient have the radiation in lower end thing. Then that the cases like we can avoid.
Okay. I think we are short of time. We are just exceeding time. So can we just go ahead to the next speaker? Sharma sir? Okay. Okay.
Please go ahead, Samir.
Okay. So I get the opportunity to introduce Dr. Ashwin Masurkar, who is our next speaker. Innovative surgeon, a good friend, maybe a good philosopher. Executive committee member of IAGES from South Zone, has helped in National Guidelines Committee for Minimal Access Surgery for Hernias, and now he's going to talk to us about his own procedure, trans-abdominal retromuscular repair for ventral hernias. Over to you, Ashwin.
Yeah. Hello, everybody. Thank you for having me here. Please share your screen. Yeah. You're seeing my screen? Yes.
Yes.
Yeah. Okay. So thank you very much. This is about my own technique, which is close to my heart. And we had this problem. In our case, it was the expensive disposables for coated mesh. Therefore, we were looking at ways to combine a TAPP repair and into a laparoscopic technique. So now if you look at the emerging evidence about ventral hernia, the sublay repair has gained popularity. Midline closure has gained a lot of popularity also. So we started this just like a TAPP repair, because at the time that's what we were doing, suture TAPP, which was simple. We go in, create a transverse incision and a flap. And then we upgraded to more and more complex procedures like what you're seeing right now. This is for a large fan and steel after post open hysterectomy. So we put in our first trocar in the epigastrium, just to the left of the midline, and we're taking a transverse incision on the peritoneum and the posterior rectus sheath, and we're raising a flap now, one on each side of the rectus abdominis muscle, the retrorectus spaces, and this flap can be cleaved very easily on either side of the midline. In the midline, one must be careful to see that you dissect. You can see that the linea alba is being carefully separated from the posterior rectus sheath. The flap can go all the way down to the pubic symphysis. And once that is done, we are seeing two defects. One is on the posterior rectus sheath and peritoneum, and the other defect is anteriorly. So we close the defect with number 1 PDS. I don't use any barb sutures. I'm very happy with the knotting properties of PDS. we take a running suture. Also, we take a bite on the hernial sac so that we can evert it and reduce the incidence of seroma formation. And once we've closed that, the next step is just to put a mesh inside. That's the end of the closure. Then we can also repair do a midline closure. That is, we can do a linea alba plication, and we just fold the mesh. We use the regular medium weight polypropylene mesh, and we close it just as you would do for a TAPP repair. Now the problem comes to do this for centrally placed defects. We have to modify. We flex the table to increase the distance from pubic symphysis to the epigastrium. We ensure an ergonomics in the OT to have a monitor low level. We start from above downwards and then from below upwards, creating two flaps. And this is not lateral port working, but we work on mirrored ports, one's from the superior edge and one from the lower edge. Now look at this. This is the greatest advantage of approaching a ventral hernia transabdominally rather than extraperitoneally. When you have an obstructed hernia or you have bowel inside, you're always unsure about how you're opening the sac. So here you can open the sac under direct vision. You can reduce the contents under vision. You can look for any Swiss cheese defects, and you exactly know what is happening because you're dealing with this hernia from the point of origin and not in the one plane ahead as you would do extraperitoneally. And this is a very wide working space, so anatomy is very nicely demonstrated here. So these are tricks to see that you carefully separate, preserve the linea alba, and just cut the insertion of those fibers of the linea alba onto the posterior rectus sheath so that you preserve a bridge of peritoneum and preperitoneal pad of fat, as you can see. In an incision hernia, this is pretty tricky to be in the right plane, and this is just with practice. But you must see that you have the rectus abdominis muscle bare. As you go lower down, you have to safeguard the inferior epigastric artery. And on the left side of the screen, you can see virtual live view where the way I stand. So this is just the port positioning is just like a TAPP in a triangulated manner. It's highly ergonomic to work, and you can go very much down. And then if you need, you can just close the posterior defect first. And after that, we insert 3 ports in the lower abdomen and start working from between the legs of the patient. And here you can see a very precise division that's happening of the linea alba from the posterior rectus sheath. And you can see that bridge of peritoneum with preperitoneal fat and the cut edges of the PRS. Next thing what we do is we close the midline, and then we put in a mesh. And this thing had to be further carried whenever we had patients of wide divarication of recti, so that could we add posterior component separation like transverse subdominus release. And this could be incorporated into TAR in the TARM procedure because we were getting a wide view. So this is a case where there was wide divarication, a previous LSCS case. And we started from the upper end, going from above downwards, cephalad to downwards, and then we are creating this flap of peritoneum and posterior rectus sheath. Now, one must be very careful as you're raising this flap laterally. You must stop at the linea seminaris, or else you'll end up injuring the neurovascular bundles. And remain in the right plane is the important thing to avoid bleeding. This is the interfoveolar ligament, which brings up it's a derivative of transversalis fascia, which brings up the inferior epigastric vessels. You must preserve that carefully. And when you divide the interfoveolar ligament away from the PRS, you can enter into a preperitoneal space. So now we introduce 3 trocars in the lower abdomen, and now these trocars are coming into the retrorectus space. They are not intraperitoneal. And now you can see on the left side of the screen, I'm working from below upwards, and I again raise this flap. I cut transversely, open one rectus space. Now in the midline, one must be in the preperitoneal space rather than trying to be retrorectus, because otherwise you can very easily take down the linea alba along with this flap. And this is the important thing that you should see. You can see a bridge of peritoneum with the preperitoneal pad of fat. lateral extent is to stop at the linea seminaris. You'll have smaller vessels which are supplying from the from the inferior epigastric or superior epigastric to the PRS, which should be carefully divided. Now that's the crossover fibers from the linea alba attaching to the PRS. And we are now in a retrolinear plane that is also called the fatty triangle, which was described with reference to Reeve-Stoppard repair. This is just a replication of the open Reeve-Stoppard repair, and with a giant reinforcement of the retromuscular space. So now, since this patient needed a lot of medialization for midline closure, we had to do a transverse abdominis release. Now, this is incision on the posterior lamina of the internal oblique aponeurosis. And once that is incised, it exposes the belly of the transverse abdominis as it inserts onto the posterior rectus sheath. Now, we can do this with the harmonic scalpel, but you must be careful as to keep the active blade towards the anterior surface and away from the peritoneum. Otherwise, you'll have buttonholing. So now you can extend that. You can go almost straight right up to the diaphragm. Now I start from above downwards usually when I do transverse abdominis release. Now this is going from lower flap.
Ashwin, Sarfraz,
Yes,
I have to interrupt you. We have overshot the time.
Oh,
So,
okay.
yeah. So sorry. Don't want to do that to you. And I would request the chairpersons to, because we have international people also waiting.
Thank you very much, Beg. And I really congratulate and thank Dr. Ashwin Masurkar for a beautiful presentation. I'm sure the young surgeons will be very much benefited with your combination of these techniques, and it will help this part of the world a lot. Now, just due to shortage of time, I'm going to introduce, I'm taking this opportunity to introduce Dr. Sumant Rai. He's the consultant advanced laparoscopic bariatric and GI oncosurgeons, Ruby General Hospital and Cancer Center, Kolkata, India. Dr. Sumant Rai, we met before. Yeah. And before asking you to come over, I really thank all the organizers and remarkable Congress. And many Bangladeshis are joining this Congress, and I'm so proud of being a part of this Congress from the Society of Endolaparoscopic Surgeons of Bangladesh. Thank you. Sumant Rai, go with your presentation.
Thank you. Shall I start, sir? Okay.
Yeah, of course. You go on.
Thank you. Good evening, everyone. My topic of video presentation is TAP repair for ventral hernia and how I do it. So we all know that TAP is a time-tested technique for groin hernias over the years. On the other hand, IPOM is a standardized technique for repairing ventral hernias. Although there are certain issues like post-operative pain and placing intraperitoneal foreign body like mesh. So there are other newer techniques are coming up which are becoming popular. But why not a TAP for ventral hernias, which is technically easy and simple procedure? So suppose there is an umbilical hernia like 2 centimeter or 3 centimeter defect like this case. So if you want to repair that, so this will be my OT setup. So patient should lie on a supine with arms tucked by side. Patient should be preoperatively fully catheterized, should be placed in the bladder, and rise should be inserted. And surgeon should stand on the left side of the patient, monitor on the opposite side of the surgeon, and camera assistant on the left side of the patient. So to start creating pneumoperitoneum, you have to gain access through with Willis needle from Palmer's point, and after that you have to place the 5 millimeter port at the left upper quadrant as lateral as possible, and under vision with a 5 millimeter camera, you can place another 10 millimeter port, which will become your the principle of hernia repair is same as any other hernia repair. So creating an operator flap, closing the defect, and place a mesh. So but the most important step after content reduction is the creating a preperitoneal flap. So whenever you are start creating peritoneal flap umbilical hernia, you start from the left upper quadrant of the abdomen at least 5 to 7 centimeter away from the defect margin, and you have to ask your assistant to becomes ergonomically easier. And one thing is more important, another thing is more important, you have to take along with the peritoneum, you have to take pre-peritoneal flap with the pre-peritoneal fat with the flap, so that you should go along the grazing along the posterior rectus sheath. So here you can see that I am creating the flap with pre-peritoneal fat and peritoneum, so that PRS becomes completely bared, and there might be some small point of bleeding which can be easily cauterized. The reduction of the hernial sac is a tricky part, because sometimes hernia sac is densely stuck or it is very thin. So the trick is to pull your hernia sac with the left hand instrument as down as possible and divide as distally, so that the peritoneal rents become smaller, because ultimately you have to close all the peritoneal rents, but you don't have create a nice floppy peritoneal flap. So another thing here, there is a cord-like structure you can see below the below the umbilicus, just below the umbilicus, there is a median umbilical ligament, and that is a median umbilical ligament. You have to go above it, you have to divide the median umbilical ligament and go above and beyond that. So once you reduce the sac, you are on the opposite side of the flap, and then the similar kind of flap creation should be done on the opposite side also. So the principle is to create at least 5 to 7 centimeter area all around the defect, keeping the defect in the center, so that you can have adequate space for placing a nice size mesh. So once you are happy with the creating the peritoneal flap, you can close the defect. That is an important part, because closing the defect reduces the chance of serum formation, also the postoperative bulge, and closing the defect can be done by any non-absorbed suture. One can use barb suture, which becomes a technically easier part. And another thing is the closing should be nicely done, and after closing the defect nicely, the next part is closing the peritoneal rents. So once the defect is closed nicely, you have to close the peritoneal rents with absorbable suture, which you can use is 20 Vicryl or Vicryl rapidly absorbable Vicryl. You can close the peritoneal rents nicely, so that none of the mesh area should be exposed to the bowel. So once you close the peritoneal rent, you can place a regular polypropylene mesh. That is you can use a macroporous medium weight polypropylene mesh, which you regularly use for inguinal hernia repair. And that is the biggest advantage of doing this repair, because you can reduce the cost of this technique compared to IPOM drastically, and you can offer this technique to many people, so that they can afford and enjoy the advantages of laparoscopic mesh hernia repair surgery. And mesh fixation, regarding mesh fixation, you can use with 2-3 point fixation suture. Initially I used to do 5-point fixation. Now I am doing only 1 or 2 point fixation, because that's a closed space, then there is hardly any chance of mesh migration. So after fixing the mesh, and the final step is to close the peritoneal flap. And peritoneal flap closure is as similar as any other tap repair for inguinal hernia. I do it with 20 Vicryl suture. Because again the cost issue is there. One can use barb suture, or one can use tacker to close the hernial and the peritoneal flap. So peritoneal flap should be nicely closed, because no part of the mesh should be exposed again to the bowel. So that is the essence of this tap repair for enteral hernia, because some 2-3-4 centimeter defect, here you can use tap repair nicely, and so that you can with affordable cost you can give advantage to many a patient. So that completes the procedure. And again, this is a post-operative view. You can clearly see the port positions, and there is no bulge over the umbilicus, and this is a completely painless procedure. You can mobilize the patient within 4 to 5 hours of the operation, and compared to IPOM or IPOM plus technique, it's almost a painless procedure, and you can discharge the patient within 24 hours of operation. So I'll show few other peritoneal flaps that I did in different quadrants of the abdominal hernias. Like this is again an umbilical hernia, where you can see a nice thick peritoneal flap is created, and this is a peritoneal space. There is a hernia defect, and you can see the PRS is completely bared, and this sac is completely excised in toto. Again, for lower abdominal hernias, where is you can place the port in the upper abdomen, and surgeons should stand on the head end side. And again, lower abdominal peritoneum is comparatively loose, so creating peritoneal flap is much more easier compared to the upper abdominal. So lower abdominal hernia, this is a case of incisional hernia from the tubectomy scar. So you can see a nice peritoneal flap is created out, almost keeping the defect in the center. Again, again there is a case of lateral abdominal, or there is a case of Spigelian hernia. Again, you can use this technique for lumbar hernias. Hernias also, you can see the external oblique visible from the defect. So there is again keeping the defect in the center. I have dissected almost 5 to 7 centimeter all around the defect, and the rest of the procedure is same: defect closure and placing regular polypropylene and closure of the peritoneal flap. So that is the advantage of this technique, tap repair, compared to other technical innovations. So my experience, I adopted this technique over the past 2 years, done 23 cases in different abdominal, all quadrants of abdomen. So seroma in only 3 cases, which I managed conservatively, and no evidence of recurrence till date. So those who want to start this technique incorporate this technique. So I recommend to start with the primary umbilical or primary hernias up to 4 to 5 centimeter defects, preferably lower and mid abdominal hernias and single defect. And you have to take care of the previous operative scar. So you can easily start doing, and then you can go on to recurrent hernias. So my take home message would be, it's a very cost effective technique, almost no postoperative pain. It's a technically easier technique compared to other newer techniques which are coming for ventral hernia repair. It's a reproducible. You can do it for any abdominal hernias and up to 4 to 5 centimeter defect, and definitely needs patience and good surgical suturing skills rather. So thank you INDO-UK SURGICON organizer and all the chairpersons for allowing me to and giving me opportunity to show my video. Thank you.
Thank you, Shumanto. That was a very nice demonstration of the use of peritoneal flaps in different locations in the abdominal wall. And you, in fact, went through the entire scenario in good time. Thank you very much.
Thank you.
So we seem to be in a race against time. So without further ado, I would like to invite Professor Jignesh Gandhi for his presentation on...
Please
Yes,
say the stop, sir. Please say the stop.
Hello.
You stop share, Sumanta.
Yes, sir. I have stopped sharing because of my. Shall I start it?
No, you have to stop
No,
sharing.
you will have to stop sharing.
Actually,
So not stopping, sir.
Then
Yeah.
Jignesh will come. Right.
stop. Yeah, right.
Thank you.
Okay, well, Jignesh, the floor is yours. Jignesh is professor of surgery at the KEM Hospital, Mumbai, and brings with him years of experience with hernia repairs. It's yours, Jignesh.
Thank you, sir. At the outset, thank you, everyone. I have no disclosures, and I thank the organizers for allowing me to give this talk today. I felt that rather than saying how I do it, I thought how I did it. That's what should be the right way. So initially what I did was I teamed up with experts, and I found my mentor and mentors. And you can see some of them are the prominent faculty in India today. The next step I felt was that if I have to go up the ladder and learn the 8FRS ventral, when I'm at the base camp, I should select easy cases. And as I go up my learning curve, cases was that, I should take up cases which are, you can see here, this is a case which was in my initial period, which is a patient with a 5 centimeter defect. I counseled the patient very well that this is the way I'm going to operate you. And I also told the patient that since I'm going to be in the early part of the learning curve, I'm going to do a hybrid approach. And most important, I selected a patient with the diet, there is no divarication of recti. The next thing is I understood the CT scan of the abdominal wall better, because this is an operation which is a pure anatomical operation, and one needs to understand the landmarks like the linea seminalis, the linea alba, where all each structures are going. The further step was I taught myself and my team members the anatomical concept, that where are we going to go, what do you mean by crossover, how do you do the crossover. So these are the diagrammatic from one of our residents who beautifully has shown this, how do we go about it, because if you understand this, you can understand the next steps very, very easily. The Achilles heel of this operation is a crossover. So if you can see here, this is again one of the paintings done by one of my residents, and this is the area where you have to cross over. You have to go very, very close to the linea alba when you're doing a crossover, because if you do a crossover a little few millimeters away, then you can land up wasting this much part of the posterior sheath, and those few millimeters can land them into an operation from reach to pass getting converted to TAR. So it is very, very important to understand that. So I do my crossovers usually from the right side and the left side both. When I was learning, now I do it from one side alone. The second important point which you have to also learn is the third dimension of the anatomy. The port positions are always lateral and they are skewed at an angle and they are never perpendicular in an E-step operation. Always a word of caution for people who are watching that do not select a case of diastasis as your first case, but if you're doing that, remember that when you're making this incision and you're going to go over, you have to understand the CT scan that there is about 4 to 5 centimeters of diastasis, whatever it is. You have to go through all that area and then go to the opposite side, because a crossover in a diastasis is always very challenging. This is one of the most important points which everyone should remember. And then once the patient finally comes on the table with understanding of all these things, I identify my linea seminaris initially on the ultrasound in all my cases, do my surface markings myself, plan my ports on the table as you can see here, put the patient in the right position and the trolley and where I'm going to stand, understand the ergonomics pretty well, and then always remember the safety and applying the sequential devices for the compression, because these procedures are long duration. You should not have a DVT in this kind of patients. It's very important. Once you have learned all these things, then I will now show you how I technically do it, because we have got a holistic approach. So this is my patient. As you can see, I put my ports 2 5 millimeters, 1 12 millimeter, and one on the opposite side. This is the optical drone entry. I call it as a drone entry because I use this optical trocar. And actually, you can see that I'm swinging my way and using it like a drone. The sharp edge of the trocar helps me dissect, and I can almost tell you that my half of the rectus sheath on the opposite left side is always dissected with this. So you can beautifully see here, you can get a nice fluffy plane there, and you can dissect this as much as possible. Then the next port comes in, and once you have the next port coming in, you do the further dissection with the help of scissors, and you clean up to reach the summit. This is my third port coming in now. You can see the entire space come up. The next step now is the Achilles heel or the crossover. And as I told you, the red is dangerous. So stay very, very close to the linea alba, because if you miss this few 5 millimeters, there's a problem. I always use a blend mode with a small burst of 30. And you can see here, I use a spatula. Sarfaraz was earlier mentioning about hook. So the choice is yours, but this is the way. I use a combination of spatula and the hook. I use the heel of the hook and I do my opening of the PRS. The next step is that you start going on to the opposite side and you dissect it. So once you have done the dissection here, this patient had a small amount of diastasis. What is a trick for the PRS? To identify, you can see here, there is a twitching which you can see. So you can see the twitching, there is no twitching here. This is the PRS of the opposite side. So this is one small trick which you can learn about how to identify the PRS on the opposite side. Having done that, you open up the posterior rectus sheath onto the right side. You have already done the left side. The next step is the sac opening and omentostasis. I call it as omentostasis because omentum doesn't have any smooth muscles. The hemostasis in the omentum is very, very important, because once it bleeds, you cannot have an exposure of what's happening. So you can see here the omentum is completely delivered. If it is a bowel, I'll be probably using a sharp dissection. I do a good hemostasis of the omentum completely. This is a volcano sign which has been described in the publication now. So now you are heading towards the lower part and dissecting the entire leaf stopas vein on both the sides. Having done that from cranial to caudal, now you are left with a small defect here, which you can see in the PRS. There is no need to close the edges together. You just need to bring things together. And if you can see very carefully, I use a barb suture and I do a kind of a plicating suture here, so that I get a good bite of the PRS. Unlike taking a single layer, I fold the layer of the PRS. Once you have done the closure of the PRS, the next is VRS. You can see fantastic suturing. There are peer patient things like, Sarfaraz has been doing, Dr. Ramana, great job. It's always better to learn from these guys. So this is a backhand suturing, and you close the linea alba from below upwards completely, step by step. One needs to practice this, and for this, sometimes I use an ethylon number 1 or a proline number 1 and close it right from below till upwards and close the entire linea alba. This is a very, very important step. The choice is yours, which one you want to close first, the ARS or PRS, but usually my choice is to close the PRS first, followed by the ARS. So you can see here, these are the last few sutures in the closure of the anterior rectus sheath. And once you have done, you have to measure the space. So this is the vertical dimension of the space. You can see that this is what I do the marking, and I find out with the 5 centimeter overlap how much of mesh I'm going to put. Then the transverse marking on both the sides. because there is no end to the dissection. You can keep on going as much as you can. Anisotropy of the mesh is very, very important. You can see this. This is the hard side of the mesh. This is the flexible side of the mesh. The flexible side of the mesh should always be craniocaudal because that is how the linea alba is. And this is the red carpet rolling technique. You can refer to my video later to see this. This is just in the fast forward. So what happens with this red carpet is you put the mesh inside there. The other end, this is the caudal end. You hold it there and you can just roll the carpet and the entire mesh opens up. I always use in a medium weight polypropylene mesh in all my cases. And you can see you can roll it up and it opens up very well. Now, whether to fix it with a glue or a tacker, the choice is yours. I have used a secure strap in this patient and I have found it that it doesn't cause any problem. In the initial cases, we have even intraoperatively gone inside and seen. The next thing to do is very important, the desufflation test. So I desufflate the abdomen and then resufflate again to see that there is no folding of the mesh. Because if you have a folding of the mesh, your integration will be poor. And if you have a good hemostasis, you can close it without putting in a drain. I thank my resident, Dr. Amay, to help me out for this. And this is my dream ETAP-RS. The next case is to be done with the right team. It's very important to build up the team. And finally, I would request the organizers that the next sessions in the conferences like this should not be how I do it, but it should be how you can do it. Because when you do a good operation, you are always very happy. But when you see people around you replicate what you have done, you feel the proud and the pride in the whole operation. So I think it should be something which you can do it, giving all the technical steps. Thank you very much for your kind attention. And I invite you all for the ANZ meeting coming up on the 7th of November. Thank you very much. Sarfaraz, I've kept up to the time. It is just about 1 minute left. Thank you very much.
Thank you, Jignesh. Yeah, that was a great presentation. Somehow I cannot really open my video because it was stopped by the host anyway. But all the 4 master videos were really great. And I believe and strongly believe that everybody enjoyed them thoroughly. And starting from Shiva Kumar to Jignesh, we really enjoyed thoroughly. So I hand over the mic to Anil to wrap up the session.
Thank you, Naeem. I would, in fact, pass the mic over to our man Sarfaraz. He has been the boss right since the morning. Right. So the mic belongs to him.
No, thank you very much.
Thank you.
I am the Krishna running the chariot for you guys, and you are the Arjunas today. So my job is to keep the time. I'm just a very glorified timekeeper. That's all. Thank you so much. I really enjoyed this session and I really enjoyed the chairperson. Everybody in this session was fantastic. I thank you all very much.